Okay, hi again everyone. With our second part of cranial ultrasound teaching. So we discussed on our first video what are we usually looking for, what are our basic views, what should we be aiming for as standard with our scan. So all the picture that you've seen last time was all about the normal findings. So with this lecture, we're trying to cover for the abnormalities that we look for from our perspective as pediatricians, intensivists, neonatologists. So what is expected from a cranial ultrasound scan from our perspective or from our angle? What should we be looking for? So our perspective is not like a proper radiologist or radiographer perspective where they can pick up a lot of stuff, a lot of stuff. We need to pick up the obvious or the hazards or the thing that might affect our care for our children as a screening test or as a follow-up test, to be more convenient to help with our planning and our care, basically. So with each scan, you should look for the anatomical distribution. So now you know that what is normal, so you need to make sure that you're seeing what's normal where it should be. You should be sure that there's no midline shifting, that the flux cerebri is where it is, and that there are no abnormal structures that you're not familiar with coming up on your scans. You need to look for IVHs, intraventricular hemorrhages, hydrocephalic changes, which you also can follow up, PVLs or periventricular leukomalacia, which again you can also follow up. You need to look for cystic formations. You can test for hypoxic ischemic injuries, and I'll show you how. Brain edema is a bit tricky, really tricky, but I'll also show you some tricks to look for it. And AV malformations. Well, basically what we're discussing is specific AV malformations for cranial ultrasound, which is the abnormal vein of Galen shunt, which also we're going to discuss later on with this presentation. So I'm not going to discuss the anatomical distribution because again it's just looking for the normal being normal. So we're going to start off with IVH directly. What are the grades of IVH? We've got grade 1, which is hemorrhage limited to the subependymal matrix. We've got grade 2, which is hemorrhage in the interventricular cavity extending into less than 50% of the ventricular system or ventricular cavity. Grade 3 should be a hemorrhage that is extending to more than 50% with acute dilatation of the ventricle. Grade 4 is any of the previous grades, so it can be a grade 1, 2 or 3, but with an extension in the brain tissue, so it's an intracerebral hemorrhage, excuse me. So knowing that, we should look for what does it look like. So if you look at this picture, it's not the most brilliant picture, but it was also a bit interesting and I'll also explain later. So this is the lateral ventricle. It can be the right or the left. In this case, it's the left parasagittal view because it's written downstairs. This is the choroid plexus, so we know where it is. So basically, when you look at that, and there's like an echogenic finding here, where the germinal matrix lie in the ventricle, which is this area. So the connection between the most anterior part of the anterior horn and the middle zone of the lateral ventricle here, there is a small dimple normally. This small dimple is where the germinal matrix lie or the ependymal layer lie. So this hemorrhage there is subepidermal because, and you would say, oh, why is it subepidermal? Because it's going into the ventricle. Well, it's not really going to the ventricle, it's pushing the epidermal layer up. And you can appreciate that it's really confined to the area here, so it's not extending anywhere else. So this is how a grade 1 IVH can look like. It can look less pronounced than that, but this is how it can be really obvious from our angle as pediatricians again. So this is a grade 1 IVH. And then this is another finding for grade 1 IVH, which is the less pronounced one. So this one is not lifting the epidermal layer really up, so it's really confined where it should be. And this is from the coronal view. So going with the basics, you screen with coronal and you find this here. You can be sometimes not that sure about this being a hemorrhage, right? Because what if it's a choroid plexus? Because you can find something here as well, so that can be choroid plexus, and your angle might be not brilliant, like your probe might be a bit tilted. But then you go for the sagittal view to confirm your concerns, and it's there. It's not connected to the choroid plexus. It's really pronounced. So this is how you know. This is how you go with your scanning. So this is a grade 1 subepidermal hemorrhage. This picture is a bit of a concerning hemorrhage, to be honest, but it's as concerning as it looks like. It's a grade 2. Why did I choose this picture? Is because there are a lot of teaching that come out of this. So I know that the ventricle is not really pronounced on the picture, like it's not really shown, which is not really good. But again, this is where the subepidermal layer is, so the hemorrhage is starting here, extending all the way to be connected with the choroid plexus. But here's why there's another teaching. So this is, what is this? This is obscuring the posterior horn. While the choroid plexus shouldn't do that, it should be lying on the curvature. So this is a clot in the posterior horn, which is coming from this hemorrhage being a bit old. So it formed a clot back there. So this is not the best picture for a grade 2, but I found it interesting just to show also that you can find extensions that can be timed. But if you want a better picture, then this is a grade 2 hemorrhage where the subepidermal layer is raised, but the hemorrhage is extending into the ventricle here and there, but it's not covering more than 50%. And you can appreciate that here as well. So on the coronal, you can't really tell the grade from the coronal view with this one, but when you go sagittal, you can see it properly. So this is how grade 2 IVH look like. So why do we have different presentations? Just because you need to appreciate that a hemorrhage doesn't always look like one picture. It can get different views, different pictures, different timing, which will affect how it looks like. And then with this hemorrhage, this is a bit of an old grade 3 hemorrhage because the blood is getting reorganized into a clot here. You can appreciate that it's not like a fluid spilling everywhere, so it's a bit confined from here. But again, this one is covering more than the usual 50% of ventricles, but because the ventricle is dilated, you'd think that it's a bit tricky to say 50%, but I want you to always appreciate the real ventricle. It shouldn't be that dilated. So this is a grade 3 hemorrhage because it's covering more than 50% of the ventricle, but because the ventricle also being a bit dilated, so it's a bit it can be a bit less obvious. But the dilatation in itself is one of the findings that you would expect with a grade 3 IVH. Look at that from the coronal side, so you can appreciate that this side specifically is covering more than 50%. Like 100% sure that this is covering more than 50% on this side, which is the right side. Okay? And then you go to this slide where you can see an intracerebral extension of the hemorrhage, which makes it a grade 4, no matter what is the grade in the ventricle. So this is a grade 4 IVH. You can see that here as well. So, and you can see that there's a midline shift. It's pushed to the right side. The whole cerebral content is pushed to the right side, and you can see a bit of dilatation on the right ventricle as well. So going back to summarize, because I know you can get really confused with the slides going forward without comparing them. So this is a grade 1 IVH, subependymal layer, localized, not going anywhere else. Grade 2 covering less than 50%, so this is the choroid plexus, so the hemorrhage is here, and there's no dilatation in the ventricle. Then grade 3 with a dilatation of the ventricle, and then extending into the intracerebral matter, where it becomes a grade 4. Okay, so now you know that you've got IVH. You can just say there's hemorrhage, right? Why it's really important to know what grade is it? Well, first of all, if you've got an IVH, it's important to pick it up early, because when you're briefing the family afterwards, you need to know what you're worried about. So you're worried about post-hemorrhagic hydrocephalus, you're worried about PVL, you're worried about seizures, you're worried about cerebral palsy, and you're worried about mental retardation. All of these can be sequelae or complications of IVH. But how often do they happen? Well, with grade 1, which is the subependymal, is about 5 to 9%. With grade 2, it can go up to 15%. And then you go to grade 3, where the possibility of a complication comes from anywhere between 30 to 40%. And then with grade 4, it becomes more ominous, because it can go all the way up to 70% of children having grade 4 hemorrhage having one of the complications or more than one of the complications that are mentioned here. So and obviously it's not just about the percentages, it's also about how pronounced the complication could be, like with something like cerebral palsy or mental retardation. So according to the grade, you would expect also the CP or the mental retardation to be worse. So the grade 1, it can be just like some difficulties with learning math or something in the normal spectrum, but it can go on to be full pronounced mental retardation with grade 4. So that's why it's important to also understand the grades. So even if you can't be sure with your screening which grade is there, and you think it's enough to say there's a hemorrhage, which is really enough as well, because basically you're going to escalate to a CT at that point, which is going to be justifiable. But it's also important to understand the grade, because maybe with grade 1 you don't need to do anything. You don't even need to go to CT, but you need to follow up or get a radiographer to follow up for you. And also it's important to know what you're talking about when you're talking to the parents or briefing them, or what are your expectations, because sometimes with a grade 4 hemorrhage, when the complications are already being really pronounced, like unretractable seizures or something like that, or a PVL that is progressing, sometimes a discussion can be escalated to like a modification of escalation of care. So you need to understand what you're doing. And then, so that was IVH as our first abnormality. Then going to ventricular dilatation. So what do you need to know about ventricular dilatation on your screening? So you need first to know that there are indices for ventricular dilatation, but most of them are just for neonatal brains. So it's good for neonatal units, but if you're using a cranial ultrasound out of that spectrum, like with an infant who is 2-month-old or 3-month-old, then they don't apply. The one that is mostly used in neonatal units is the ventricular index VI and the Levine index. But roughly, because we don't need from our perspective to be that specific, you need to know that the lateral ventricles should be less than 13 millimeters at the posterior horn level, and the third ventricle should be less than 10 millimeter wide And again, ventricular dilatation or hydrocephalus should be always assessed as a serial measurement rather than a single one, because the angle of your probe can be tricky sometimes, so you need to confirm that it's a progressive thing rather than just one measurement, although sometimes it's like this picture where it's really pronounced. So if you look at this picture, what do you need to know about your measurement? First of all, you need to know that the midline is important. So if there's shifting, you can't really rely on your measurements. If there's anything that was manipulating how your midline is represented, then it could be tricky to measure. And then you need to know where you're measuring from to where. So you basically, this is how you're measuring at your ventricular index. So from the midline to the most lateral point of the lateral ventricle. This is how you measure. And which view are we measuring at? You remember that on coronal views, C3, I like to say, or C4, I think. C4, where the third ventricle is shown. So when the third ventricle is in the picture, you draw your midline, you get the measurement for the lateral ventricle. Some ventricles, as we said, don't really need measurements to appreciate that they're dilated. But again, it's good to get a measurement for your follow-ups if you want to. So you can appreciate here that actually the lateral ventricles, both of them are really dilated to the point that even here, here, the posterior horns have come into the field again because of how dilated they are. Because if you think about the ventricles looping around, coming back here with their tails, so the tails are dilated to the point that they're all showing in the same field here, really big. This is a good picture, I think. So all of the ventricular system is dilated, so lateral ventricles, posterior horns of them coming up again, and then the third ventricle in the middle being dilated, fourth ventricle is dilated. But what is really important is where the star lies. So what is happening there? Basically, there is no cerebellum, and this is a Dandy-Walker malformation. So this is how cool cranial ultrasound can be. Just a scan, even if you're not an experienced radiographer, you can appreciate that there's something missing here. So if you revise the first lecture, you would understand that this is where the cerebellum should be, and that will get you the diagnosis. So this is a Dandy-Walker malformation, absence of tonsillar vermis and opening of the cisterna magna with the fourth ventricle in the same field, causing disturbance with the whole ventricular system, getting to this image of full-blown hydrocephalus. So I'm not expanding with ventricular dilatation more, because it's all about appreciating how dilated the ventricles are, if they're not slit-like, if they're progressing, if they're getting more than the measurement that we mentioned, 13 millimeters for lateral ventricles or 10 millimeters wide for third ventricle. And just keep an eye for abnormal structure always. And then the next thing is PVL, or Periventricular Leukomalacia, where I think you guys need just to get a bit focused here, because this is where it gets a bit tricky. So what is PVL? It's basically malacia or weakness or ischemia. So it's a malacia that is coming from ischemia from the watershed areas. So the watershed areas are areas that are not getting a direct blood supply via an artery or an arteriole. So they get their blood supply by water shedding from the distant capillaries that stop at some point there, and then the blood supply just diffuses to these areas. So these are the most liable areas to get ischemia with hypoxic events. So what is pointed at here with the arrows is basically part of the watershed areas, but because of that, this is where you would expect a normal flare on the ultrasound. to happen. So this flare is normal. Why is that important? Because PVL, when it happens, it is shown on the cranial ultrasound as an exaggerated flare. So how do you know that this is normal flare? This is normal flare because basically it is where it should be, on the side of the posterior horn of the lateral ventricle, both on the coronal and the sagittal view. It is less pronounced or equally pronounced in echogenicity to how the choroid plexus is, which is a very important marker. Okay, and it's not having any cystic formations on it, so that's how you know it's a normal flare. But if it's exaggerated, like it's brighter than the choroid plexus, then it might be a PVL grade 1. So we say it might be, but it is a PVL grade 1 if it persists being highly echogenic for more than 7 days. So a PVL grade 1 is an exaggerated flare for more than 7 days here, or an exaggerated flare than normal again in any of the other areas for more than 7 days. So a flare happening here for more than 7 days can be PVL. An exaggerated flare happening here for more than 7 days is PVL. But a normal flare here, no matter how long it is normal. And here you're not allowed to have normal flares usually, except with premature brains sometimes. And then if it starts showing small localized cysts on the parietal lobes, then it's PVL grade 2. If the cysts are extending to the occipitofrontal lobes, so either from the parietal side here to the frontal here, or from the parietal side here to the occipital lobe here, then this should be classified as grade 3. But then if these cysts extend to be subcortical lesions, then this is grade 4. So it's all words here, but we're going to show the pictures and it's going to be more understood there. So what is that? So now we're going all the way to the the far away view or the sagittal view, either right or left. So when you go to S3, right or left, so that should be showing your parieto-temporal lobes, right? So what you can appreciate here is a flare. It seems really exaggerated, right? So this is a flare where it shouldn't be, and it's also exaggerated. So if we go back to a choroid plexus, you would appreciate that it's really bright. If that persists for 7 days, that's grade 1. Now you can see some cysts where the usual flare is, usually. So these cysts are only here on the parietal lobe. They're not extending to the occipital, not extending to the frontal. So this is grade 2. And then you can appreciate that these got extended to the occipital lobe, right? And you can see them here on the coronal view. Well, you can't really see that they're going to occipital, but at least you can appreciate how they look like on the coronal view. So this is grade 3 because it got to the occipital lobe. And now you can really appreciate how these cysts are going all the way to the subcortical area. So that's grade 4. So now you know that there's PVL and you know the grade. Why do we need to know that? Basically, it's telling you something about your patient. It's telling you that your patient is liable to have diplegia, quadriplegia, and mental retardation or mental retardation. Okay, so these are serious because PVL means CP, mental retardation, until proved otherwise, and you need to keep an eye on your patient, and you might need to start physio. So, and it's important to convey that to the parents as well after having discussions apparently with the team. But that's PVL, and that's why it's important to look for it. And to be honest, like the key so far with IVH, with hydrocephalus, with PVL, from the cranial ultrasound point of view, is the follow-up. You don't just localize an abnormality and say, oh, it's there. you need to see how it progresses. You need to see if it's evolving or devolving, and that will always guide your management, and that will also guide your expectations. Okay, so going to the next point in your screening test, which is looking for cystic formations. So cysts are basically different than each other. There are normal cysts, abnormal cysts, and interpretation for cysts is usually different than the other lesions because it lies on a lot of factors, like, are you looking for them? Are they incidental findings? Do they mean anything to any abnormalities that you've got with the brain, your expectations, infections? So it always depends on the patient, really. So these are choroid plexus cysts, which are absolutely normal to find. They are not pathological. They are just normal variant, and you shouldn't really get concerned about them, but it's good to mention them on your report if you're reporting. This here is a cyst that got formed because of a blood clot, so it's post-hemorrhagic, and you can see the blood clot there. So there was a hemorrhage that got the ventricle a bit dilated, but then formed a cyst in the extension here, which might denote ischemia. So this one you could be concerned about. This is what we call a string of pearl, which is also a normal incidental finding. So it's basically ventricles that got developed in on the way of development, got a bit of a cystic deviation here, which is fine. And then I thought about bringing up some miscellaneous findings that are related to the first point of your screening, which is looking for structural abnormalities or anatomical abnormalities. And it also adds to your experience of doing a cranial ultrasound scan, where you could appreciate that you might pick up a big diagnosis just via scan. So these pictures are showing holoprosencephaly that can be part of or either be isolated or a part of a syndrome, especially midline syndromes like trisomy 13 or Smith-Limley-Opitz syndrome. So this is alobar holoprosencephaly, and this is semilobular holoprosencephaly. So apparently this is worse than this one. They are both craniodevelopmental abnormalities where the brain hasn't developed very well, and you would expect a lot of global developmental delay with either of them, but apparently this one is worse. What is this one showing? So this is really cool and really interesting to know that you can pick up via cranial ultrasound if you're paying attention. These are calcifications, periventricular calcifications, and here they are again. So what is that denoting, or what should you screen for when you find these happening like that? Basically, you should look for torch, because what you're expecting with periventricular calcification is usually congenital CMV. But it's a really good thing to pick up, to be honest. This is a choroid plexus tumor that is usually a benign tumor. But I know that this one can be tricky. Some people can perceive that as a hemorrhage, and you need a CT usually to confirm your finding here. But if you see something like that, I know that you're going to go for an objective scan, which is fine, but at least you can appreciate that one of the potential diagnoses is a benign tumor. Here, what happened is the lateral ventricles got unified with the septum pellucidum in the middle, so they are all being one, and this is septo-optic dysplasia, which is a congenital disease. but you need to really be concerned about the pituitary with this one, because it's part of the problem here that the pituitary can be absent. Again, this is a Dandy-Walker malformation. No cerebellum, vermis, no cerebellum, tonsils as well, and well, global hydrocephalus with all of the ventricles. This one is cool because basically I got this one because of a personal experience with a patient from before. So you look at this scan, you're thinking there's nothing much happening. It might be just some light artifact or a flare or something, but actually it's all localized to the midbrain. Okay, so the midbrain is the thing that is getting a bit hyperechoic, and it's identical on both sides. It's bilateral, no variation. You can't really say that it's a unilateral problem, right? So it's a systematic disease or a systemic disease. So what do you think is happening here? Basically what's happening here is that you've got, oh, this baby's got a metabolic disease, which is affecting the midbrains on both sides. So in this specific patient, and happens to be the same finding with the patient that I had, and because I was querying that, that's why I looked it up. He had Ley disease. So it's really interesting to know that you can also pick up something that might denote a metabolic disease. So if you happen to find something like that with a keen eye, you might need to think about metabolic disease, even if the child didn't start to present anything. Just at least something to discuss with your consultant, maybe. Okay, so we've discussed most of what you can pick up with the cranial ultrasound. Now we get to something that is tricky but is important, which is how we use Doppler with cranial ultrasound in a basic way to get the resistive index, which can tell us about other stuff. So part of what I told you initially on the first slide on this presentation was that we might screen for hypoxic ischemic events using the cranial ultrasound. So this is part of how, because the resistive index is one good tool to tell us about that, and I'm going to tell you how. So basically, let's start with the basic. So if you choose to get the color on your scan, getting the trying to get to the mid-sagittal view, where you can appreciate the shadows of the third ventricle and the fourth ventricle going downwards, you will see the anterior cerebral artery here. You're gonna see the artery and the vein connection around the corpus callosum, okay, going to the pericallosal artery, and then the vein of Galen is coming from here. Okay, so again, anterior cerebral artery, pericallosal artery, vein of Galen. Usually with your hand tilting you can appreciate the veins as well beside the pericallosal artery. So the vein of Galen is really important, and also we're going to come up to that. So that's what you can see from the sagittal. At least that's what is important for us from the sagittal view. And then if you look at the coronal view, you can also get the circle of Willis, where the anterior carotid artery is coming up from both sides to meet and get you the anterior cerebral artery here, which is more pronounced when you tilt the probe a bit here. And then the MCA goes on both sides. Again, you need to tilt the probe to get them, but this is the MCA to the right side, and there's the MCA to the left side there, but it's not shown on this picture. So now you know your arteries that are coming up here. So a lot of people use this view to try to study if there's difference on resistance from one side against the other, trying to scan for ischemia, blood clots, obstruction of one of the arteries. And it's a very good tool if you master it, but we're not going to get a lot of complicated discussions with this presentation. We're just going to jump to the basic, because if we keep going, you can also get a very nice view on the temporal window for the circle of Willis to see how the arteries are going. But again, we're going to go back to the basics. So a good point to start with when you're looking, when you choose the color, is just before you do anything, look for the vein of Galen, because the vein of Galen can have an abnormality that is, if it's picked up really early, it can be a game changer for the child. This is how a vein of Galen malformation looked like. So basically, the vein of Galen can have a malformation that is basically an AV malformation. It connects the arteries with the veins in a very abnormal way, and it causes a lot of hemodynamic instability, and it can cause heart failure, brain hemorrhage, and a lot of problems if it's not picked up early. You can pick it up clinically by auscultating the interfontanelle, hearing a murmur, or using the cranial ultrasound. So if you're scanning a child, be sure to look for that using the color, because if you don't put the color, you might not see it at all. This is from the coronal view, so you can see how the malformation looks like. And now going back to the resistive index, which is your second part of the Doppler or the color scan approach. So normal range for resistive index is anywhere between 0.6 to 0.85. Low values denote ischemia and hypoxia, so anything below 0.6 is showing a sign of an ischemic or a hypoxic event. High values are denoting increased intracranial pressure, so it can be a sign of edema or hydrocephalus pushing against the brain, or it also can be a sign of a distal occlusion, distal to the artery that you're having the resistive index on, and that's how they use it with the middle cerebral arteries to any site to just scan for ischemia. So how do we calculate the resistive index? Is basically it's going to be a computed calculation. You don't need to worry about it usually, but if you're using one of the old machines or not having the modality specific for cranial ultrasound, it's basically related to the peak systolic velocity and the end diastolic velocity at the ACA and MCA, and then there's a calculation. We're not going to go through that, but you can, if you're stuck, you can Google it. So basically, you get the color on your screen, and then you choose pulse wave, and you point your arrow or your line to be as parallel as could be on its way to meet with basically the genu here. So the ACA is going this way, and if your line goes that way to study the resistive index here, that's going to give you a very good picture, because it's less likely to be affected with a distal occlusion at this point. Okay? And you get a wave that is looking like that. So you freeze and you choose measure, and you get the highest systolic peak. This is the peak systolic velocity, and the end diastolic velocity, where it just stops before the next peak, the next systolic wave. And if you get both of those, choosing the RI on your machine, a number is going to come up. Okay? Again, to show it again. So you can get it anywhere in the artery, but it's always good to have it being parallel, because as you can see here, he had the study somewhere where it wasn't that parallel. You can see that the wave wasn't really good. Then he adjusted and the wave became more pronounced. So Now you know how to do the resistive index. So how can we assess for hypoxia and brain edema? So first of all, you need to know that cranial ultrasound is not the best modality for any of those. But you need a collective approach with data collection. So you need to know the history, the examination, what you're expecting, and add to it your cranial ultrasound findings to try to come up with, is it hypoxia, is it brain edema, what is happening here. HIE can cause brain edema as well, so it can be a bit tricky because, as I said, you're expecting the resistive index to be low with hypoxia and high with brain edema. So if a hypoxia happened that was pronounced to cause brain edema, you can have a normal resistive index being a bit tricky because there's a factor that is getting it low and a factor that is getting it up. So if we're talking about hypoxic ischemic injury, you're expecting a lot of other findings as well. So maybe PVL, so hyperechoic shadows around basal ganglia, around other parts that can be PVL, as I said. Or you can sometimes, because of the pooling that happens with the resistance going down with hypoxia, you can have hemorrhage. But again, as I said, the resistive index should be low. Brain edema, other finding that can help you with diagnosed brain edema other than the resistive index being low is finding that the ventricles and the sulci being obliterated. So if you look at this picture, you can't really appreciate the ventricles, right? Like they're really squashed. You can't even see them. Okay, so this is brain edema. But on the same scan, there is something here that is a bit hyperechoic here, there. So the guys weren't really sure what's happening, so they went for a CT, and that's what they found. So this is basically a stroke that was acute and bad enough to cause brain edema. But to be honest, it's really difficult to pick this up if you're not looking for it. But it's also good to know that your cranial ultrasound scan, if you're thorough enough, can pick that up for you. So that all happened because of prenatal asphyxia, okay, where brain edema can happen from the pronounced ischemia that you had. This is another picture of brain edema, just brain edema, where you can see that the ventricles are nowhere to be seen. Sulci and gyri being really obliterated and squashed against each other. So you can see all of these like lines here. This is not how you usually see the brain structure, right? So this is severe brain edema. If you do a resistive index on this one, you'll find it higher than 0.85. Okay, again, if you're not sure about your coronal view, you go for the sagittal and you can see that the ventricles, like, they're really squashed here. Okay, so I know it's a bit confusing. Try to go back and forth with this video being a bit slow, and the previous video as well, but your take-home message is cranial ultrasound is your first choice bedside screening in neonates and even in infants. We've used it a lot in ICUs other than neonatal age groups, but when the fontanelle was open. You need to know your aim of the study. You're not a radiologist, you're not a walking CT, you're not expected to find everything, but at least you can pick up what you need, like overnight if you're stuck, not having the feasibility to move a child being really critical. So at least you know what you can aim for with your study, what you're looking for. But if you're good enough and you will experience, the cranial ultrasound can be a highly sensitive screening tool. It's very good for follow-ups. It's massively brilliant to follow up things with ultrasound rather than exposing children to a lot of CT exposures with a lot of radiology exposures. And the cranial Doppler is a very promising tool. As I said, it's even been used in adults now from the temporal window and with different modalities. So it's an emerging science, so it's always good to be to have some experience with something that is promising, that can be used more in the future. You don't want to be really behind when things develop further. So I can add to that that I would always recommend that you should always try to perform more scans, being supervised by someone who's basically knowing what they're doing and you're doing and can evaluate your scans for you. Thank you, and be sure to give me your feedback and comments, please. Thank you.